1. Major insurance changes for GLP-1 drugs, impact on weight loss patients. 2. Wegovy and Zepbound price drop, will access improve? Obesity drug costs explained. 3. How to get GLP-1 weight loss drugs covered by employer health insurance. 4. CVS drops Zepbound, weight loss drug coverage cut explained, GLP-1 costs and impact. 1. Major insurance changes for GLP-1 drugs, impact on weight loss patients. Imagine spending years finding a treatment that finally works for managing your weight, only to have it suddenly yank away due to changes in insurance coverage. For many patients relying on GLP-1 medications like Zepbound, this nightmare scenario is becoming a reality. But here's where it gets controversial. Are these decisions driven by cost-saving measures or do they genuinely prioritize patient health? Let's dive into the details and explore what this means for millions of people across the country. Tara Ikobeksai recently found herself in a frustrating situation during a doctor's appointment focused solely on her health insurance. A major shift in her prescription benefits meant that Zepbound, a drug she had spent years trying to access, would no longer be covered. "I'm completely outraged," she said. "It's not just stressful, it makes me furious." Starting next week, CVS Caremark, one of the largest pharmacy benefit managers in the US, will exclude Eli Lilly's Zepbound from its list of covered medications. This move affects millions of individuals who rely on CVS Caremark to manage their prescription drug plans. Why the change? According to CVS Caremark, there's another medication deemed safe and effective for treating obesity that may come at a lower cost. In a letter sent to patients using Zepbound, the company explained, if you refill your current medication on or after July 1, 2025, you'll need to pay the full price. The alternative being pushed is Wegovy, a competing GLP-1 drug made by Novo Nordisk, along with a few other options that are often considered less effective. CVS insists this decision aims to encourage competition between pharmaceutical giants Eli Lilly and Novo Nordisk, potentially driving down prices for consumers. Our formulary strategy maintains clinically appropriate coverage while using competition to drive lower costs, CVS Health stated. However, critics argue that pharmacy benefit managers, PBMs, including CVS Caremark, play a significant role in escalating drug prices nationwide. With approximately 25 to 30 million people impacted by this specific formulary change, the stakes couldn't be higher. When it comes to weight management, experts emphasize that GLP-1 drugs aren't interchangeable. Each patient responds differently to these medications, and abrupt changes can disrupt progress. Dr. Tracy Zvaniok, Director of Policy Strategy and Alliances at the Obesity Action Coalition, points out that society still clings to outdated beliefs about obesity. "We are looking for quick fixes instead of recognizing obesity as a chronic disease," she explains. "Until mindsets align with the science, we'll continue seeing policies that create unnecessary barriers for patients seeking care." The process of finding the right GLP-1 medication is often painstaking. Dr. Jody Dashe, an endocrinologist at Beth Israel Deaconess Medical Center and assistant professor at Harvard Medical School, describes it as a trial-and-error journey. Some patients experience allergic reactions or severe side effects like nausea, constipation, or stomach pain with one drug but not another. Switching medications can derail weight loss efforts and exacerbate shortages of already scarce supplies. When announcements about coverage changes hit, my inbox floods with messages from worried patients, Dashi says. For those who finally found success, with good tolerance and steady results, having to switch feels devastating. She adds that navigating insurance-related hurdles consumes precious time during appointments, leaving less room for discussing patient concerns and overall health updates. Adding fuel to the fire, another major insurer, BCBS Massachusetts, plans to exclude all GLP-1 drugs for obesity treatment starting next January, reserving coverage only for cases involving type 2 diabetes. While the Blue Cross Blue Shield Association highlights its commitment to addressing the obesity crisis through nutrition and physical activity programs, critics question whether limiting access to proven treatments undermines this goal. About 60% of patients don't stay on GLP-1s long enough to achieve meaningful weight loss, notes David Merritt, Senior Vice President of External Affairs for the association. Though adherence rates are improving, he stresses the need for more data to ensure these expensive medications provide lasting value. Yet, studies show that tirzepatide-based drugs like Zepbound tend to yield better weight loss outcomes compared to semaglutide-based ones like Wegovy. Plus, Zepbound boasts additional indications, such as treating sleep apnea in obese patients. For individuals like Tara Ecobexai, losing access to Zepbound feels like a personal attack rooted in bias. After jumping through hoops to prove previous treatments failed, she finally saw life-changing results with Zepbound. Her blood sugar levels stabilized, and she felt validated in her struggle against societal stigma surrounding weight. This medication showed me I wasn't alone, that I truly needed support, she shares. Losing it mid-year has left her feeling betrayed. While exceptions might be possible, the appeals process is lengthy and burdensome. Meanwhile, Eli Lilly offers some relief through its LillyDirect platform, allowing uninsured patients to purchase Zepbound directly for $499 per month. Still, this option remains inaccessible for many. So, what's your take? Should insurers prioritize cost-cutting measures over individualized care? Or does the responsibility lie with drug manufacturers to lower prices voluntarily? Share your thoughts below, we'd love to hear from you. 2. Wegovy and Zepbound price drop, will access improve? Obesity drug costs explained. The price of hope is dropping, but so is access to life-changing obesity treatments. While Wegovy and Zepbound, two groundbreaking GLP-1 receptor agonists, are seeing their prices decline, the reality for many patients remains stark: these medications are still out of reach for millions. Let's break this down. Wegovy and Zepbound, which have revolutionized obesity care, cost around $500 per month for those without insurance, a figure that's far beyond the means of many individuals. Even for insured patients, coverage is inconsistent, with some plans offering little to no support. Dr. Matt Majewski, a Duke University professor specializing in obesity treatment, puts it plainly: the medications should be available, but the question is at what price and can people sustain that? This dilemma forces doctors to think creatively when treating patients, yet there's cautious optimism that prices might drop further in the coming years. These drugs are part of a wave of GLP-1 receptor agonists that have taken the medical world by storm. For instance, Zepbound, manufactured by Eli Lilly, generated $2.3 billion in U.S. sales during the first quarter of this year alone, making it one of the company's top earners. Meanwhile, Novo Nordisk's Wegovy has secured approximately 200,000 weekly prescriptions in the U.S., contributing nearly $1.9 billion in first-quarter revenue. But here's where it gets controversial: despite their popularity, access remains a patchwork of availability. Mercer, a benefits consulting firm, reports that more large employers, those with 500-plus employees, are now adding coverage for these injectable drugs. However, Novo Nordisk notes that 85% of its insured U.S. patients pay $25 or less per month, a stark contrast to the $500 burden faced by the uninsured. And this is the part most people miss: even when coverage exists, it's often incomplete. Dr. Beverly Chang, a New York-based physician and advisor to both Novo Nordisk and Eli Lilly, explains that many insurance plans only cover a fraction of the cost, leaving patients responsible for hundreds of dollars each month. For example, Medicaid programs at the state and federal levels, including Medicare, which serves those over 65, typically exclude these drugs for obesity treatment. Drug makers offer financial assistance programs, but these are often limited in scope. Chang emphasizes, coverage is not the same as access. Employers, too, are wary. Some have dropped coverage entirely due to the high costs. Pharmacy benefit managers, PBMs, which negotiate drug prices on behalf of insurers, are also playing favorites. For instance, CVS Health's PBM removed Zepbound from its national formulary in July 2023, opting instead to prioritize Wegovy. This decision forced Dr. Chang to rework treatment plans for patients who relied on Zepbound for its reduced nausea side effects. To help patients navigate this maze, some clinics, like Dr. Courtney Younglove's office in Kansas, now send prospective patients a video link showing how to check their insurer's website for coverage before scheduling an appointment. Unfortunately, some patients cancel their visits altogether after discovering they lack coverage. Compounding pharmacies once filled the gap during shortages by producing cheaper, off-brand versions of Wegovy and Zepbound. However, the FDA recently declared the shortage resolved, effectively ending this practice, except for personalized prescriptions. Hims & Hers Health, a telehealth company, offers compounded doses of semaglutide, the active ingredient in Wegovy, tailored to manage side effects, starting at $165 per month for 12 months. But this is a contentious issue. Eli Lilly has sued pharmacies and telehealth providers, including Hims, over their sale of compounded versions of its drugs. Novo Nordisk recently ended its partnership with Hims after the company continued compounding, citing safety risks due to unregulated foreign suppliers. Hims, however, claims it adheres to U.S. quality standards and uses third-party labs to verify drug potency. Despite these disputes, both drug makers still charge around $500 per month for uninsured patients, a sum that consumes roughly 14% of the average U.S. household income, $43,000 annually. However, there's hope on the horizon. Both companies are developing pill versions of their treatments, which could enter the market within a year. These oral alternatives might drive down the cost of the current injectable formulations. Younglove shares a practical workaround. Some of her patients save 15% by sourcing doses from Canadian pharmacies. She notes that competition from international markets, combined with the impending arrival of pill versions, could spark a price war in the US. I think we are in the early stages, she says. I have hope. The Associated Press Health and Science Department received support from the Howard Hughes Medical Institute's Science and Educational Media Group. The AP is solely responsible for all content. Now, here's a question for you. Should the high cost of these life-changing drugs be a barrier to treatment, or is it a necessary investment in innovation? Share your thoughts in the comments below. Do you believe pill versions will make these medications more accessible, or will the pharmaceutical industry continue to prioritize profit over patient needs? 3. How to get GLP-1 weight loss drugs covered by employer health insurance. Here's the deal. Even though GLP-1 drugs are a game-changer for obesity and related health issues, millions of Americans are stuck paying sky-high prices or turning to unsafe alternatives. These medications, which help the body regulate appetite and blood sugar, have transformed treatment for cardiometabolic diseases, but their exorbitant costs and limited insurance coverage are creating a crisis. Most people with employer-sponsored health plans can't access them, leaving many to rely on unregulated, lower-quality compounded drugs made in facilities that don't meet U.S. safety standards. But even that option is disappearing, as the FDA recently ended the shortage of brand-name versions, effectively banning the cheaper alternatives. But here's where it gets tricky. While the US spends over $1,000 a month on these drugs, patients in countries like the UK pay as little as $150. President Trump highlighted this disparity, pushing pharmaceutical companies to match global pricing, but no laws currently force them to lower costs. However, there's a way to make GLP-1s more affordable, by rethinking how insurance plans and drug pricing work. Most employer health plans are built on a budget shared between employers and employees. Adding coverage for weight loss treatments would likely mean higher premiums, which many employers are hesitant to do. Yet, with 88% of Americans struggling with metabolic health issues, the stakes are huge. Employees are increasingly demanding access to these drugs, and some employers are open to the idea. The question is, how can this be made financially viable? The answer lies in simplifying the pricing system. Right now, drug companies sell GLP-1s directly to patients for around $500 a month, but insurance plans often pay $1,000 due to rebates and coupons from pharmacy benefit managers, PBMs. These middlemen take a cut, and manufacturers offer discounts to make the final price competitive. If we eliminate these middlemen and let employers subsidize part of the cost, say, $300 a month, employees could pay as little as $500, a price closer to what's available abroad. But this system wasn't designed with patients in mind. Rebates were originally meant to influence which drugs PBMs and insurers favored, not to ensure affordability. With only 2 major GLP-1 drugs on the market and clear clinical data, there's no need for these financial incentives. Instead, recent deals between drug makers and PBMs have prioritized profits over patient care, creating a tangled web of approvals and restrictions. This complexity leads to another problem: prior authorization hurdles. Doctors spend hours fighting to get patients approved for these medications, even when they're medically necessary. By streamlining pricing and coverage, we could cut through this red tape and focus on what matters: health outcomes. GLP-1s aren't without risks, of course. They require careful monitoring, and decisions about their use should always involve a doctor and patient. But the current system's lack of transparency and fairness is a bigger issue. Should the government step in to ensure these drugs are accessible? Or is it up to employers and insurers to adapt? The Trump administration's decision to block Medicare from covering GLP-1s for obesity has only deepened the divide. Meanwhile, the Biden team took a different approach, recognizing the public health potential. As the debate continues, one thing is clear: fixing drug pricing isn't just about money, it's about saving lives. What's your take? Do you think the government should mandate lower prices, or should the market handle it? Share your thoughts below. 4. CVS drops Zepbound, weight loss drug coverage cut explain, GLP-1 costs and impact. A major player in healthcare has made a controversial move that's sparking heated debate. CVS Caremark, one of the US's top pharmacy benefit managers, PBMs, has decided to stop covering Eli Lilly's popular weight loss drug Zepbound. The decision, which has left many patients and advocates scrambling, centers on a growing tension between cost control and access to life-changing medications. But here's where it gets tricky: this isn't just about money, it's about how healthcare decisions are being shaped by behind-the-scenes negotiations that often bypass patient needs. And this is the part most people miss: the ripple effects of this choice could redefine how we approach obesity treatment in America. Zepbound, the brand name for Eli Lilly's tirzepatide, was hailed as a breakthrough for its remarkable results in clinical trials, where participants lost up to a quarter of their body weight. Originally developed to manage type 2 diabetes, is now FDA approved for chronic weight management, joining other GLP-1 drugs like Wegovy. These medications work by mimicking hormones that regulate appetite and metabolism, making them some of the most effective tools in the fight against obesity. But their soaring prices have put them in the crosshairs of PBMs like CVS Caremark, which argue that their egregiously high list prices are unsustainable. According to CVS spokesperson Phil Blando, removing Zepbound from coverage could save clients 10% to 15% annually in anti-obesity medication costs. However, this decision isn't without consequences. Blando noted that exceptions for medical necessity will be considered on a case-by-case basis, leaving patients in limbo. For many, this isn't just a financial issue, it's a matter of health stability. Dr. Christopher McGowan, a gastroenterologist specializing in obesity medicine, called the move deeply disruptive. He explained that GLP-1 drugs aren't interchangeable in practice, even if they seem similar on paper. Switching medications mid-treatment can undo progress, trigger weight regain, or cause new side effects. Once a patient finds a medication that works, preserving that success should be the priority, he said. Yet, he warned, financial contracts between PBMs and drug manufacturers are increasingly dictating clinical decisions, not medical expertise. Eli Lilly, the drug's manufacturer, has pushed back, emphasizing its commitment to patient access. The company highlighted programs like LillyDirect's self-pay pharmacy solutions, which offers discounted rates for patients without insurance coverage. A single-dose vial of Zepbound, for example, can now be purchased for around $500. But critics argue that such solutions are a band-aid for a systemic problem, the rising cost of life-saving treatments. This isn't just about Zepbound. It's a microcosm of a broader conflict in healthcare. PBMs, which act as intermediaries between insurers, pharmacies, and drug makers, are under pressure to lower costs, but at what price? As patients face limited choices, the question lingers, should healthcare decisions be driven by financial contracts or by what's best for individual health? What do you think? Do you believe PBMs should prioritize cost-cutting over patient access, or is there a middle ground? Share your thoughts below. This debate is far from over.